My.
Welcome to the Week in Diabetes and Endocrinology from Hormone Insight. This podcast delivers a summary and perspective on the top news of the week that endocrinologists, diabetologists, and internists can't afford to miss. This podcast is intended for healthcare professionals. For the week ending April 24th, 2026, I want to talk about the FDA's expanded approval of Tzield for children as young as 1 year old with stage 2 type 1 diabetes, the AACE annual meeting in Las Vegas, and what's worth watching. A new Attain-1 subgroup analysis showing Orforglipron delivers consistent weight loss across every BMI category. The arrival of generic Dapagliflozin and what it means for cost and access. A large target trial emulation study on GLP-1 receptor agonists and erectile dysfunction that you're going to get asked about, and a small but provocative thyroid ultrasound finding out of AACE that could change how we triage indeterminate nodules. Let's get into it. First story, and in my view, the most meaningful regulatory news of the week. On April 22nd, the FDA approved a supplemental biologics license application expanding the indication for Tzield, that's Teplizumab MZWV, Sanofi's CD3-directed monoclonal antibody, to include children as young as 1 year of age with stage 2 type 1 diabetes. Let me be precise about what stage 2 type 1 disease means because the terminology matters. Stage 2 is defined by 2 or more diabetes-related autoantibodies, GAD-IA2 insulin autoantibodies, or ZNT8, plus dysglycemia, but not yet frank hyperglycemia. These are children on a moving conveyor belt toward insulin dependence. Until now, Teplizumab was approved from age 8 upward, based on the original TN10 study from 2019, which delayed the onset of stage 3 type 1 diabetes by a median of roughly 2 years. What changes now is that we can intervene much earlier. The expanded approval is supported by Phase 4 Petite T1D data. 23 children under 8 years were enrolled, evaluating safety and pharmacokinetics of the standard 14-day intravenous Teplizumab infusion regimen. The reported probability of remaining free of progression to stage 3 type 1 diabetes was about 89.6%. Now, I want to be honest about what we know and don't know. 23 children is a small trial. It was a safety and PK study, not a powered efficacy trial. The 90% progression-free number is promising, but it's from a short-term Phase 4 study with limited follow-up. We do not yet have decade-level outcomes data in toddlers. What this approval does is open the door to screening and intervention in the youngest children with 2 or more autoantibodies. The sibling of a type 1 child, the child with a family history, the incidentally detected autoantibody case. That's meaningful. It shifts the conversation with families from watch and wait to we have a disease-modifying option. Practically, this raises a workflow question most pediatric endocrinology practices aren't ready for. Are we going to universally screen for T1D autoantibodies in high-risk children? Are we set up to administer a 14-day IV infusion to toddlers? What about cost? Tzield runs close to $200,000 a course. Insurance coverage in this age group will be the bottleneck, not the biology. The direction is right. The infrastructure lags the science. That's going to be the story of the next year. Story 2, and this is a live event, not a paper. The AACE annual meeting is running April 22nd through 24th in Las Vegas. There's a lot happening. Let me flag a few things worth watching. On obesity, we're getting subgroup analyses of the Orforglipron Attain-1 trial. I'll talk about the BMI subgroup in a moment. We're also likely to see updated data on survodutide, retatrutide, and CagriSema in Phase 2 follow-up cohorts. And there are several presentations on real-world data in patients with obesity who cannot access GLP-1 agents, which is going to matter more now that the CMS balance model is rolling out. On thyroid, there's a presentation I want to come back to at the end of the episode. It's a small but provocative ultrasound finding that could help us triage indeterminate nodules. And there's a significant session on socioeconomic determinants of obesity care, specifically showing that lower income and education levels negatively affect patient experience and expectations of weight management care. This is not a surprise to anyone who practices in the real world, but having it formally quantified at a major society meeting matters. it pushes us towards structured counseling approaches that account for the patient's starting point, not just their BMI. If you follow the meeting on social media, the hashtag is AACE 2026. A lot of the signal comes through late-breaking posters, not the main plenary sessions. Story 3, and this connects directly to AACE. A new subgroup analysis of the Orforglipron ATTAIN-1 trial was presented this week, looking at whether weight loss varies by BMI class. Quick reminder on ATTAIN-1. Phase 3, 72 weeks, over 3,000 adults with obesity, randomized to Orforglipron at 6, 12, or 36 milligrams versus placebo. That's the trial that led to FDA approval of Foundayo on April 1st. The new subgroup analysis stratified patients across the BMI spectrum, from overweight through class 3 obesity. The reported headline is that placebo-adjusted weight loss with Orforglipron was consistent across every BMI category. There is a modest gradient, a small tendency toward higher percentage loss in lower BMI patients, which mirrors what we've seen with injectable GLP-1 receptor agonists. But the key message is that clinical benefit did not vanish at the top of the BMI range. Now, a few points. First, this is reassuring. One concern with oral GLP-1 agents has been whether they could deliver meaningful weight loss in severe obesity where higher drug exposure may be needed. This subgroup analysis suggests yes. Second, the pattern of slightly better response in lower BMI is a pattern we should explain to patients, not hide from. Someone with a BMI of 45 is not going to match the percentage loss of someone with a BMI of 28. Setting expectations matters. The clinical bottom line is that Orforglipron works across the BMI spectrum. If your patient with class 3 obesity cannot or will not use an injectable agent, this is a legitimate option. You're not going to match tirzepatide level total weight loss, but you're going to get meaningful benefit. And oral once-daily dosing without fasting restrictions is a real-world adherence advantage. Before you quote any exact subgroup percentages to patients, wait for the formal publication. Subgroup data presented at meetings is preliminary until the full paper comes out with peer-reviewed numbers. Section 4. On April 7th, the FDA approved the first generic versions of Dapagliflozin tablets. Multiple manufacturers received approval covering both 5 mg and 10 mg tablet strengths. Here is why this matters. Dapagliflozin, brand name Farxiga, is approved to reduce hospitalization for heart failure in adults with type 2 diabetes, with cardiovascular disease, or multiple CV risk factors, and for glycemic control as an adjunct to diet and exercise. It also has HFrEF and HFpEF indications. It is a workhorse drug across cardiology, endocrinology, and nephrology. Brand name Farxiga has run around $550 to $650 a month without insurance. Generic Dapagliflozin is expected to come in substantially lower. Reported estimates are in the range of $288 to $405 a month depending on the discount card. That's still expensive, but it is a meaningful reduction. And over the next 12 to 18 months, as more manufacturers enter and pricing competition kicks in, I expect that number to drop further. What this means in practice: patients who have been paying out of pocket or facing high deductible plan rejection for Dapagliflozin have a real path now. Patients who were rationing pills or skipping days should have access restored. And, importantly, SGLT2 inhibitors are a class where durable, once-daily use matters for outcomes. A patient who can only afford to take their Dapagliflozin every other day is not getting the cardiorenal benefit the trials demonstrated. This also puts pressure on empagliflozin pricing. Empagliflozin is still under patent in the US. Once clinicians have a cheap, effective SGLT2 alternative with strong cardiorenal outcome data, the pricing conversation for empagliflozin changes. Watch the next 12 to 18 months. One implementation note. Generic versions are therapeutically equivalent, but not every pharmacy stocks every generic. If you're prescribing for heart failure specifically, confirm with your patient that they're getting approved generic Dapagliflozin, not an unrelated SGLT2. Story 5. This one, I think, is going to come up in your clinic, so let's get ahead of it. Published April 2nd in eClinical Medicine, a target trial emulation study of GLP-1 receptor agonists and erectile dysfunction in men with type 2 diabetes. The design is a target trial emulation using electronic health records from a large US health system covering roughly 5.5 years. Adult men with type 2 diabetes initiating either a GLP-1 receptor agonist or a DPP-4 inhibitor as the comparator. New onset erectile dysfunction was the primary outcome. 4,910 men on GLP-1 receptor agonists, 5,524 on DPP-4 inhibitors. The incidence of ED was 35.2 cases per 1,000 person years in the GLP-1 arm. The adjusted hazard ratio was 1.26, so a 26% relative increase. But, and this is the critical part, after applying additional calibration to address potential residual bias, the association was attenuated and no longer statistically significant. The authors themselves say the observed association is small, does not establish causality, and likely reflects underlying differences in patient characteristics or treatment selection rather than a true pharmacological effect. So, what do you tell the patient? The honest answer is this. There is a weak observational signal in a single target trial emulation. The signal does not survive careful adjustment. Biologically, we don't have a strong mechanism. In fact, weight loss and improved metabolic health tend to improve erectile function, not worsen it. If a patient on semaglutide or tirzepatide reports new ED, investigate it the way you would for any patient. Don't automatically blame the GLP-1. Check testosterone. Review the medication list for other culprits. Consider vascular workup if the risk factor profile fits. One more point, there's a separate and distinct body of literature suggesting GLP-1 receptor agonists may reduce libido in some patients, which is not the same as erectile dysfunction. That signal is real and probably deserves more discussion, but don't conflate the two. And last story, rapid fire, and it's going to be short. At AACE this week, a presentation caught my attention because it addresses a problem every endocrinologist deals with: the cytologically indeterminate thyroid nodule. Bethesda 3 and 4. You did the FNA, it came back non-diagnostic or atypia of undetermined significance, and now you're stuck trying to decide who gets surgery, who gets repeat FNA, who gets molecular testing, and who gets observation. The presented study reports that the presence of thick post-microcystic reflection on ultrasound in indeterminate thyroid nodules after FNA was associated with malignancy. Now, small study presented at a meeting, not peer-reviewed yet. Do not change practice on this, but the direction is interesting. We have been hungry for better non-invasive triage markers in Bethesda 3 and 4 for years. If this replicates, it could become a useful adjunct alongside molecular testing platforms like Afirma or Thyrosec, or could help in settings where molecular testing isn't readily available. Keep an eye on the full publication when it comes out. In the meantime, if you see thick post-microcystic reflection on ultrasound of a Bethesda 3 or 4 nodule, don't discount it. It may be a pointer worth acting on, but wait for the peer-reviewed data before you change your triage algorithm. That's your week in diabetes and endocrinology from Hormone Insight. If you found this useful, share it with a colleague. And if you disagree with anything I've said, I hope you do, because that's how we get better. You can find show notes with all the references at hormoneinsight.com. Until next Thursday, keep questioning the evidence, keep learning, and keep putting your patients first. Thank you for listening. I